Thanks, Andy. Appreciate all your support in helping set this up. Friends, welcome to today's webinar. Our host today is Paul Galshut. Paul is a research staff chaplain at M Health Fairview at the University of Minnesota Medical Center. He's a former Transforming Chaplaincy Research Fellow, and he's the convener of the Hospice and Palliative Spiritual Care Research Network for Transforming Chaplaincy. Andy, let's go back. There it is right there, right? Paul is also actually the instructor for Research Literacy 101. So a number of you may have taken Research Literacy 101 and know what kind of thoughtful and helpful instructor Paul is. For those of you who are interested in the 101 and 102 courses, here's the website where you can find them. And if we go back 2 slides, Andy, right, I think, we just want to kind of give you one more. There it is. We want to give you a heads up. There's a couple of other webinars that will come up before the end of the year that Transforming Chaplaincy is sponsoring. On December 1st, we're going to do one that's going to look at racial differences in spiritual care, some of the evidence that already exists about that, and thinking about what kind of research we should be doing going forward. And then we're going to do another webinar on December 15th with colleagues from Ohio State University, looking at how they use big data, really big data, guys. This is really big data to examine who gets, among cancer patients, who get spiritual care. So we're looking forward to those. We hope you'll join us for them. Paul, I'm going to turn this over to you. Thanks so much for all your good work organizing today's webinar.
And thank you, George, for your leadership and your guidance for being the director of Transforming Chaplaincy. Just want to linger on that for a second. So friends, I also get to serve as this convener of the Hospice-Palliative Spiritual Care Research Network. It is for all palliative clinicians, whether you are a spiritual care provider, chaplain, or whether you're someone who is the advanced practice nurse, you are the physician, the clinical social worker, or health services researcher, like we'll hear from Dr. Ernecoff here in just a moment. But we want to invite you into this space. Number one, we want to broaden our base, so we want to invite you into a place to connect with others. And if you are a researcher, a place for you to disseminate some of your research. And the peer-reviewed articles is a space for that, as well as these webinars just like these. So you'll be the first to hear about when these are emerging, so you can put that into your calendar. And if you're interested, it's also a place where you can explore or even coordinate perhaps for future spiritual care research within the realm of hospice and palliative care and medicine. So I guess the moment you perhaps been waiting for, our presenters and our respondent here. So it is my privilege to present Dr. Natalie Ernecoff. As you can see, she has her role at there in Pittsburg. I'm gonna just move my control panel over so I can see the exact language, where she serves as the Post-Doctoral Scholar in the Division of Internal Medicine at the University of Pittsburg School of Medicine, and focuses on her research in palliative care. We purposefully didn't fill up the slide with all the other things. If you wanted to fill up the page, I do invite you to go to pubmed.gov and type in Dr. Ernecoff's name, and you'll have plenty there to fill up. So thank you, Dr. Ernecoff, for being here. We look forward to your presentation lecture with us. And then we're also quite grateful to have with us Dr. Joe Rotella. Dr. Rotella will be serving as our respondent, discussant, and reactor. I know there's different names for that. Here's just a few details that amplify, I think, our gratitude and heighten the importance of having you with us today. Dr. Rotella serves as the Chief Medical Officer for the American Academy of Hospice and Palliative Medicine. He is additionally the President and founder of CatalystHPM, and he also serves as the Clinical Professor of Medicine and Associate Program Director of the Palliative Medicine Fellowship at the University of Louisville. So Dr. Rotella, we're so glad that you are with us today. I'm just gonna minimize this. As we are doing this, I want to say a special thanks to all of you who are attending here today. We had 400 people register for this. Back in my days of serving in a congregation as a pastor, we used to say people vote with their feet. So it warms my heart to know that this many of you care about the importance of spiritual care within the research realm of hospice and palliative care. So whether you're somebody might identify as a spiritual specialist or a generalist or you're a researcher, we're so glad that you are here in this space with us. And having said all that, Dr. Ernecoff, thank you again for being with us, and turn it over to you.
Thank you so much for having me, and thank you everyone for joining us today. I'm Natalie. I am, again, at the University of Pittsburg School of Medicine. I'm a health services researcher here. I want to start out the presentation today talking a little bit about language and how I'll be using language today. We talk about spiritual care, religion and spiritual care, and existential concerns, all within the space of clinical spiritual care provision. And today I'm going to use those terms in sort of a nebulous way. They all have very specific definitions. I'll probably use them interchangeably, but I just wanted to put a note here about definitions. One thing I want to draw particular attention to is that these definitions and the use of the phrase spiritual care is not dependent on the delivery mechanism of the spiritual care. So I'm not referring specifically and only to chaplains. I'm not referring specifically or only to community spiritual care providers, nor clinicians or other clinical staff. And I'll get into a little bit about why that is the case in a few minutes. This is one definition of spiritual care that I'm going to read, and I think it's a really nice representation of the way I'll be thinking about this for today's presentation. Spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred. Spirituality is expressed through beliefs, values, traditions, and practices. We'll see themes of all of these different aspects coming up today. So this presentation will come to you in 3 parts. We're going to talk about health services research generally through the lens of palliative care, spiritual care within that palliative care context, and then talk about some workforce concerns on both the palliative and spiritual care side. I'm going to talk about my own research trajectory through a few different studies that our groups have done in spiritual care. And then we're going to spend some time talking about next steps and how to effectively do high quality research on religion and spiritual care within the context of palliative care research. So what is palliative care? Palliate is a verb. It means to make less severe or unpleasant without removing the root cause. We think about this often clinically in the context of serious illness care and meeting the needs of patients without the ability often to remove the cause of their illness. It's provided by 2 different pathways. We think about specialty palliative care as care delivered by board-certified palliative care clinicians or those who have extensive clinical experience delivering capital P palliative care. There's also primary palliative care. This is delivered by people who are not board certified in palliative care. It can be a primary care provider. It can be a specialist in a non-palliative care field, think oncology, geriatrics, nephrology. I want to draw attention to this citation, which is one bit of a lot of work on workforce concerns in palliative care and how there are not enough specialists to meet the needs of patients with serious illness. And there are also not enough interventions in the primary palliative care space to fill those gaps. And so that's something that the field is really working on. Something worth emphasizing is that palliative care with a little p can guide practice philosophy for all providers. So why is palliative care important? Patients with serious illness often experience high pain and symptom burden. They receive intensive treatment that often do not align with their goals and values for care. And serious illness care is a major contributor to healthcare costs. I mentioned this last one, not because we primarily emphasize costs, but just to note that administrators and policymakers are paying attention to these things and do look at the evidence base in this space when making decisions about funding for palliative care, and we'll get to within spiritual care programs as well. So palliative care does move outcomes. Palliative care has been shown to improve pain and symptom management, advanced care planning for people with serious illness, quality of life more generally. It also improves patient and family satisfaction. I just want to note here that in palliative care, we do think about the patient and the family as the unit of care, not just the patient. So the family is a really important part of this here, and that's the case in the spiritual care world as well. Palliative care has also been shown to be associated with utilization, particularly near the end of life. So what are the actual components of palliative care? Well, it encompasses multiple aspects of what we consider high quality patient care generally. Robust pain and symptom management for people with serious illness, ethical and legal aspects of care. This includes advanced care planning and goals of care discussions, spiritual care, structure and process of care. This is where I spend a lot of my time in the research world, is thinking about how we can redesign systems to meet palliative care needs. It includes psychological, social support. All of these domains have an undercurrent of consideration of cultural aspects of care, and then care of the imminently dying, which we often think about in the context of hospice. When is palliative care? Palliative care can co-occur with curative care, as this diagram shows. This is from the World Health Organization. I think it's a really nice picture to show the disease trajectory. So you can see sort of the patients and the families along the bottom axis. From the time of diagnosis, we often tend to emphasize curative treatment or disease-directed therapy for people with serious illness. And as that disease progresses, often symptom burden increases, decisions become more complex. And that's when palliative care becomes even more relevant as the disease progresses. And so there's this balance, though both can be delivered in conjunction, and indeed often in high quality care, they are delivered in conjunction. In the United States, curative care often, though not always, has to end when patients enroll in hospice, where the focus becomes purely on high quality, comfort-based end-of-life care. Again, it's important here we see that care does extend into bereavement. So the families really are a part of the care package when we think about, you know, who palliative care is supporting during serious illness. So where's spiritual care in all of this? These are two different diagrams, tables. The details here, I don't want to get too bogged down, but I bring these up to point out that from two high quality palliative care guidelines that include both specialty and primary palliative care, these models include existential support, but the degree to which they really engage with spiritual care specifically and all that it encompasses is really pretty slim. It has really not been a part of the palliative care conversation as much as we would like to see. So this is an area for growth within the field of palliative care more broadly. So spiritual care encompasses multiple aspects of serious illness care. And this gets back to the definition I used at the beginning. It really is very broad. This is a paper from Laura Hanson's group at the University of North Carolina, where they looked at what patients and families were getting from spiritual care support. And we saw things that, they saw things that we expected, like religious and spiritual practices, think communion in the inpatient setting or last rites, intercessory prayer or prayer with patients and families, help discussing and sorting through relationships with both loved ones and or God, but also that includes understanding of oneself and one's illness, coping with illness, providing insight into dying and processing some of those existential concerns, and also comfort more generally. So the role of spiritual care really extends beyond what we think of as structured religion or spirituality. So who's delivering spiritual care? Patients often, though not always, share a religious tradition with their sources of spiritual support. It is particularly the case among hospital chaplaincy that there might be some discordance there, though there's some evidence that that's not a bad thing, that hospital chaplains are highly trained and also have a lot of perspectives that can be applied very broadly across religious and spiritual traditions. A large minority of patients are not spiritual at all or not religious at all, though those groups of patients still see benefit from spiritual care services for the reasons I described on the last slide. When you ask patients and families where they're getting their spiritual care, they'll say family and friends, their own clergy from their communities, healthcare providers, including chaplaincy, and then directly from God or whatever higher power they believe in. So when we think about the spiritual care workforce, we have a lot of the same concerns that we have in the context of palliative care more broadly. So again, I'm going to use sort of the same structure. Specialty spiritual care, we generally think of within palliative care as chaplains in healthcare settings. So people with expertise both in chaplaincy generally, but also with experience in serious illness, for example. And then there's primary spiritual care. And we think of this as community spiritual care providers who may not have as much clinical expertise, and then other clinicians who can maybe provide some elements of spiritual care or screening of spiritual care needs, even though they may not be able to provide as robust of resources as a specialty spiritual care provider. Again, providing spiritual care with a little s can be a goal of all providers. So now I want to talk a little bit about the importance of building evidence for any intervention we're interested in, but in this case for spiritual care. And this is something that I hear over and over again from spiritual care researchers and chaplains, that we have these workforce limitations, and one way to overcome them is convincing healthcare systems, administrators, decision makers that this is important work, that it's a valuable contribution. And those systems expect evidence, high quality evidence-based interventions for spiritual support. That requires a lot of money and a lot of effort, which is of course limited by a lack of robust workforce in some settings. And so what I'm interested in is how can we break this cycle? How can we improve workforce, improve evidence, and improve the way health systems engage with spiritual care services, both specialty and primary? So to illustrate this, I'm going to talk through 3 different studies that I've been a part of, and this will just show you my trajectory. Lots of investigators have looked at similar questions, have gone beyond this, but this is just sort of my starting point, thinking about incorporating spiritual care and describing spiritual care in clinical settings for people with serious illness. The first study I'm going to talk about today is a description of current spiritual care practices in a qualitative way. So we're going to look at some quotes. We're going to look at, we did some audio recordings, and we're going to look at those data. The second study is also looking at current spiritual care practices from a much different lens. We're going to use a quantitative lens. We did chart reviews of people with serious illness to see within the medical record, how are clinicians communicating with each other through the written record about spiritual care and spiritual needs assessment. And then the third study is actually looking at clinical outcomes that are associated with spiritual care. So again, this first study is looking at current spiritual care practices from a qualitative lens. We did prospective audio recordings of ICU family meetings among patients who were in the ICU incapacitated, so they weren't able to make their own decisions, and we met with their families, their surrogate decision makers, 260 of them nearly, and we did a qualitative analysis of religious and spiritual statements, again broadly defined, that were made by either the clinicians in the meetings or the surrogate decision makers themselves. And then we also had surrogates complete demographic questionnaires that included both their self-described religion and self-described religiosity. That is, how religious they considered themselves. And here's what we found. 78% of surrogate decision makers in those demographic questionnaires indicated that religion or spirituality was either fairly or very important to them. So that's a pretty high proportion. And then we also found that only in 2 conferences, or less than 1%, a chaplain was included in those conversations. Now, we only captured 1 conversation per patient, so the chaplains could have been there in another capacity, but this was a really interesting finding, because these are very seriously ill people in the ICU. For this cohort, the in-hospital mortality rate for this hospital stay was 50%. So we would maybe expect a number that was a little bit higher. Though not to fear, we wondered, are maybe the mechanisms for primary spiritual care robust? Are these needs getting addressed just not by chaplains? And we found that also really wasn't the case. Spiritual and religious concerns only were mentioned by anybody in 16% of conversations. And in only 8 of those family meetings did clinicians attempt to further understand surrogates' beliefs. So really there is indeed a lack of engagement for a cohort of people who are their families of people near the end of life, and existential concerns for this group is notably important in a cohort that self-describes as pretty religious / spiritual. So these are some of the qualitative findings from the study. The paper reports the types of statements that families made, some different types of statements that clinicians made. But right here, I want to focus on the statements that were initiated by physicians in the family meetings. And I want to focus on this because when we think about interventions, we often want to think about how can we systematically make sure needs are getting addressed, and often that requires some type of initiation on the health system or the clinician side. So I just want to go through some different types of statements that the physicians made in a way to assess or address spiritual care concerns or needs. So one thing that people did do was ask open-ended questions. Some of them were a little bit more logistically oriented. So you can see this first one is mobilize sources of support for patients or surrogates. The example here, would you want anyone from pastoral care to come up and see her? This is a pretty common way that the clinician is doing their primary spiritual care contribution is a screen of religious or spiritual care needs. And then they refer to chaplaincy and sort of take it from there. Another is asking the surrogate about their personal spirituality or the patient's spirituality. Here the example is faith, spirituality, religion. Is that a big part of his life, his being the patient's life? And presumably could start a conversation with that. So a bit more open-ended in that case. And then another thing that people talked about was integration with a spiritual community. Here, I would say that anybody who loves him and wants to be with him, come. If you have religious personalities, priests, pastors, I would invite them. So this is the clinician giving a little bit of anticipatory guidance about what maybe the next steps would be for addressing spiritual needs for this patient and family. Another thing that physicians did was provide their own beliefs, sort of expose their own beliefs to the surrogate decision maker. This person says, I'll come by, I'll be watching, I'll be praying, perhaps to show solidarity. Perhaps this patient had expressed something previously in a previous meeting or in previous encounters, that was a place that they could engage. And then another thing we saw pretty frequently was among the few cases in which these things came up, was the physician identifying common goals of care and implications of spiritual beliefs for medical care. And this is very interesting. So this physician says, I'll tell you, my job isn't to take away hope. I'll be hoping for that same miracle we're all hoping for, but medically speaking, realistically speaking, this isn't going to improve. He's not going to get better and leave the hospital. So this physician is trying to balance prognosis, the clinical situation, and leave space for some spiritual or religious beliefs, in this case, hoping for a miracle. So with that, we wanted to look at, in this second study, how people currently practice spiritual care, but instead of communication between clinicians and families, we were interested in communication between clinicians and clinicians. So that is, what does their written communication with each other look like in the electronic health record? So our research question are, what are current palliative care practices among inpatients with late-stage cancer, dementia, or chronic kidney disease in their last 6 months of life? So this is a decedent cohort. Everyone died, and we look back retrospectively in the charts of 400 patients to see what their 6 months looked like. And all of these patients had at least one hospital stay during that time. And we assessed multiple elements of palliative care, including spiritual care, in this study. And those are the results I'm going to talk about today. So here we see, this is just a description of spiritual care. We found that a little over half of decedents were screened for spiritual care needs. That was a very low bar. Our operational definition was asking if they'd like to see a chaplain, the chaplain stopping by, like any mention of a chaplain stopping by and assessing needs. And we saw a little bit of over half identified some needs, half desired spiritual engagement. So nearly everybody who was screened wanted to have some engagement. And then you can see that among those who had their needs screened and addressed, almost all saw a hospital chaplain. So chaplains are still doing the lion's share of screening and meeting spiritual care needs. So this leaves space, this is some evidence that this leaves space for maybe some primary spiritual care intervention. So the third study we did, we wanted to look at outcomes associated with spiritual care, particularly on utilization at the end of life. We looked at in-hospital mortality and hospice utilization. This is actually the same cohort of patients I was just talking about, so the same 400 patients with retrospective chart review, and we assessed outcomes associated with multiple elements of palliative care. Again, spiritual care was among them. And here's what we found. Screening of spiritual care needs was associated with higher rates of in-hospital death. Probably the reason for that, we found that spiritual care was delivered very near the end of life. And in the hospital in which this study was conducted, there was a hospital-specific comfort order set, so that when someone transitioned to comfort measures only, spiritual care was part of that bundle. So there was automatically a spiritual care chaplaincy consult triggered. And that's probably what was moving this. So these results sort of exemplify a reverse causality problem in that spiritual care did not cause in-hospital death. That's good news. But in-hospital death actually was associated with spiritual care, that the fact that someone was dying in the hospital triggered this comfort measure order set. So what are the next steps? One is measuring outcomes causally associated with spiritual care. So I just looked at associations, and now this a next step is to actually look at some causal associations. One way to do that is to develop and test interventions in a randomized control trial format. There are lots of researchers doing this work. This is where my own research trajectory has sort of led up to date. And then once we find interventions that are effective for improving spiritual care access and moving some of those clinical outcomes, then we need to think about what are effective ways to disseminate and implement those interventions so that they can reach the maximal number of people with serious illness who can really benefit from those services. So what are some considerations for doing this high quality research? Rule number 0, and this is the most important thing I might say today, don't try to reinvent the wheel. Chaplains, clinicians, researchers like myself, we all have unique expertise, we all have unique skill sets, and working together is mutually beneficial. Not everyone needs to be an expert in what everyone else is doing, and it's a lot more fun if you can really work together, use each other's expertise, generate new questions. That's really where the bulk of this work is going to get done, is at the interface of all of these different groups of people with diverse expertise. One important practical thing is to get connected to each other by networking through professional organizations, to collaboratives. Think about like what the work that Transforming Chaplaincy is doing here is doing a lot of work to build these connections, and that's so, so important. And another thing is cold emails. Look up the research that you're interested in, the researchers who are answering questions that you're interested in, and email them and learn about their research and their papers. And even if they don't have space for collaboration, they probably know who does, and it's another way to think about expanding your network. Building the right teams is key for clinical work. We don't expect one person on any given clinical team to carry all of the weight or to start from scratch, and research is the same. Building the right teams is key for high quality research practice. So what are the appropriate questions to ask when conducting high quality research? You want to start with what question you want to answer, or what problem do you want to address? And I highly recommend building a conceptual model. This is one from one of my projects. The details are not important here, but it is so clarifying to just draw the boxes and arrows to say, okay, what might be causal? What might be some of these pathways related to a spiritual care intervention? What might that intervention look like? And how could it reasonably impact in a causal way the outcomes that I'm interested in? Whatever those outcomes are. In this case, and the case I just discussed a few slides ago, we were interested in utilization, in hospital death, hospice referral. You might be interested in quality of life. You might be interested in other ways of measuring existential distress. Other questions to consider, what is the state of the science for your question? Read the papers, read the articles, talk to the investigators doing the work in the specific topic you're interested in, and see, you know, what's the next step? Where could this part of the field go? What interventions are most effective? Do we have evidence for effective interventions already? Or what might be effective? What is there good theory for that we haven't tested well enough yet? And can we test those things to develop that evidence base? And then the last thing that's really important to think about is how you can rigorously measure the things you're interested in. So one thing that we think about a lot in research is, you know, sometimes the things that are most important are really hard to measure. And so what are things that, where are places you can compromise and say, here's a really important thing that we're interested in, and it's measurable, and there are validated instruments for capturing that, or there's administrative data for capturing that. And this is something that researchers think a lot about, is how can we measure something meaningful and also in a feasible way. I want to draw a special attention. These ideas are not my own. I want to give credit to this paper. This is a 3-paper series by Steinhauser and Balboni about the state of the science in spiritual and palliative care research. And this is a great series of papers as you're getting, if you're getting started on a spiritual care, palliative care research path. So what are the next steps for the field? One is to expand specialty spiritual care. How do we expand the workforce? How do we incentivize people to be clinicians? How do we get hospital systems to engage and expand spiritual care? We also need to think about how to expand primary spiritual care. How do we educate or train clinicians to address spirituality, address spiritual and existential concerns. I hear all the time from within palliative care clinicians that this is something that people are still really uncomfortable addressing, screening. What are reasonable ways to think about training, and what are reasonable expectations for people who aren't chaplains? So that's an area that's ripe for research. Another important piece is to identify patients' and families' spiritual care needs. What are patients and families most concerned about? How can we best screen for those needs and get those needs met by one of the two prior bullet points? And then a really important piece of this is dissemination and implementation. How do we develop scalable interventions that can be disseminated widely, that are feasible, and incorporate them into care for people with serious illness and their families? You can have the best intervention in the world that's very expensive and very complex, and it may never get implemented. And so that's a really important thing to think about when you're designing interventions and studies, is how can we really improve the reach of these interventions into communities of various levels of resources. And so with that, I would like to thank you for your time. I have this piece of art on my slide. This is Pittsburgh's own Andy Warhol, one of his memento moris. It's Latin for remember that you will die, which is a practice in art and philosophy of meditating on reminders, often skulls, of human mortality. And I think that's something we in this field do try to be very thoughtful about, and want to help others who do this work do the same. So I'd like to thank you. Special thanks to Transforming Chaplaincy, to Paul and George and Andy. I'd like to thank Dio, one of my mentors who was instrumental in helping me think through this talk. And I'd like to thank Dr. Rotella, who we'll hear from in a few minutes. So with that, I'll pass it back to Paul.
Dr. Ernecoff, thank you so much for that. And to borrow from the Hebrew scriptures, my cup overflows with gratitude as well as knowledge. And we already have some questions that are coming up, so I know that will certainly fill our time. Dr. Rotella, look forward to your slides coming up here and your response from Dr. Ernecoff's presentation and lecture here with us. I'm going to turn it over to you.
Can you see my slides now, Paul? Paul, are you seeing my slides?
You know, I am not seeing them yet. I'm going to defer to either George.
Okay, there we go. Now I can show them.
Okay, great. I see them now. Thanks, Joe.
Okay, great. I'm glad you can see it. And then I just need to do one more thing. Hang on a second, please. Turns out that I can't look at everything at once. It's just not the way it works. Okay, well, I'm very glad to join you, and thank you so much for having me. You know, being a reactor is a wonderful position, because basically I wasn't told I had to react in any particular way. And so I'm going to take a pretty big departure from that really scholarly presentation from Dr. Ernecoff and react in several different ways. First, I want to acknowledge and thank Dr. Ernecoff for several things. One is that recognizing that spiritual care and palliative care really matter. They matter to patients and families. They matter to clinicians. They're important. Also for advancing our understanding of how we actually deliver spiritual care and how we deliver palliative care. And with some of this research around utilization, it actually can help us make a business case for investing in the workforce that can provide spiritual care and that can provide palliative care. And most of all, in demonstrating the attitude of curiosity and humility, which form the foundation of good research, but also really form the foundation of spiritual care or the humanistic approach to healthcare. So I'm going to respond with 3 different perspectives. And this is all going to come from, we were just talking about research. Consider this qualitative research with an N of 1. So I guess it's just a case study. Or you can call it storytelling if you like. but I'm going to come from 3 different perspectives. One is that I would say that I have experienced a spiritual malady and healing related to that really was related to my role as a healthcare worker and in the form of burnout. Secondly, that as a palliative care doctor and hospice doctor, I've had the opportunity to provide spiritual care at a primary level within my specialty care I provide with a palliative care team. And I got to learn that from working with some fantastic palliative care chaplains. And then thirdly, I've had this opportunity to engage on a national level in some collaborative efforts to define what is quality palliative care. And absolutely that includes spiritual care, but also how we can support this move toward paying for value. And when you're moving into that, we pay for value rather than paying for volume of medical procedures, then being able to demonstrate the positive outcomes or even cost savings related to something like spiritual care or palliative care becomes very, very important. So first, I'm going to talk about my own experience with spiritual distress related to being a doctor. Sometimes I felt like I was carrying the weight of the world. I'm going to share with you 6 drawings and a few words that actually are included in the National Academy of Medicine's Expressions of Clinician Well-Being, which is an art exhibit they put together to support the Action Collaborative for Clinician Resilience and Wellness. And you can see the link there. Becoming a doctor, I put my whole heart and mind into helping others, but I was not prepared for the physical and emotional exhaustion. Sleepless nights, responsibility for life and death, and witnessing suffering took a toll. It was easier not to see my patients or myself as human. Sometimes I wanted to scream. It hurt when my patients died. I tried to be perfect. When a patient sued me after an unpreventable complication, my trust was shattered. I feared losing my colleagues' respect. I felt I was in exile. I tried to hide my suffering and pretended to be okay. My favorite mask was that of the workaholic. My own healing required accepting help from others. I leaned on my wife's unconditional love. I found a physician support group run by a chaplain at my local hospital, and I found out that my peers had the same struggles. I wasn't alone. I got counseling. I considered my options. Now I listen to my heart and reflect on my experiences through journaling, sketching, these doodles you're seeing, talking with my friends, and I'm recommitted to my core mission as a doctor, and that is to humanize the healthcare experience for patients and clinicians. This led to a transformation for me from a primary care doctor to a hospice and palliative care specialist. And I found joy again in practicing hospice and palliative medicine, where teams tend to the body, mind, heart, and spirit. And nothing beats visiting patients at home, surrounded by what they love, living their own stories, where I could be my best self, lean into my worries, and celebrate the good in life. And I want you to know that that experience of burnout and that experience of transformation for me was more spiritual than anything else. There was a physical aspect to it. I was exhausted. There was an emotional aspect to it, but more than anything, it had to do with moral distress and feeling like I should be doing work that really matters. And it just didn't, I wasn't feeling the joy anymore. I also had an experience later in my life when I had become more of an administrative doctor, where again, I felt that I wasn't having that joy anymore. And I left a perfectly good job to take a self-funded sabbatical, hired a life coach who was into mindfulness. And again, through spiritual counseling, I made my way to my current job, which is just a perfect place for me. My life coach asked me to develop a personal mantra, and this is what I came up with. I'm a commitment to trust and a source of love. I'm a commitment to forgive and a source of healing. I'm a commitment to play and a source of joy. And I would say these are all spiritual things. And so I did not experience this in a religious way. You didn't hear me talking about God, but I did experience distress and transformation and healing related to my role as a doctor, and I would call that spiritual. And then this really let me apply that in my care of patients in hospice and palliative care, where I was very lucky that I could learn the approach to spiritual care from some fantastic specialist chaplains that were part of our palliative care service at the Norton Hospital in Louisville, Kentucky, which was led by Ron Oliver. And when we had ICU meetings, the chaplain was there. And when I was seeing patients or families outside of the meeting, I was able to apply what I learned from chaplains about having that humility that I don't know the answers to everything, and that curiosity that would allow me to ask. Do you have concerns? Do you have beliefs? Would you consider yourself spiritual? How's this affecting you that way? I learned how to ask those open-ended questions. But I do want to point out that when a physician starts to do spiritual care, we have to be sure we don't bring our medical model with us. One of the reasons palliative care is so important is that it's an interdisciplinary team approach that isn't just focused on the typical medical model, which I would say goes something like this. Don't just stand there, do something. But you know, when we're providing spiritual care in that attitude of humility and curiosity, is something more like, don't do something, just stand there. Not solving people's problems, not prematurely providing reassurance is so key. And I have found that just being there and asking the right questions and really listening can open up a real channel of healing. It's been humbling as a doctor to see that. To give just one example, in a goals of care discussion at the hospital with a family, a very devout Pentecostal family, praying for a miracle for a woman who was dying of a brain tumor that we could no longer treat, and she could not survive. When we had the question about would you want, we would not recommend attempting to resuscitate her because it won't work. He said, but we're expecting a miracle, so please resuscitate her. And where the curiosity comes in is I said, well, if God can work a miracle, why do we have to resuscitate her? Wouldn't God just save her? And that's when that family member said, let me explain something to you, and told me a parable. The floodwaters were rising in a city, and everybody was up on the roof, and they're looking to be rescued. And one devout man is praying to God to rescue him from the flood. A boat comes by and they say, jump in. And he says, no, you go rescue somebody else. I'm praying to God. God will rescue me. And then a helicopter comes by and drops a ladder down to the rooftop. And he says, no, go rescue somebody else. God will rescue me. And of course the waters rose and the man drowned. And when he got to heaven and he said, God, I believed in you. Why didn't you save me? God said, I sent you a boat and I sent you a helicopter. What more do you want? And when I heard this story, I was able to ask him, what does that mean? And he said, it means that the way God is going to work is through the faith we have that even when you say your resuscitation won't work, it will work if we have faith. And that really helped me understand where they were coming from. But you don't get there if you're not curious, you don't ask. So now I want to move for a second into this idea of how this supports our move toward value, toward making sure that we have the resources to support spiritual care and to support palliative care. First, a quote from the poet William Wordsworth. This is from The Tables Turned. Sweet is the lore which nature brings, our meddling intellect misshapes the beauteous forms of things. We murder to dissect. We murder to dissect. You know, I was an English major, and sometimes I would take my favorite story or poem or novel, and I would have to write a paper about it. And just trying to write a paper about it almost always wrecked the novel for me. And so there's this idea that when we're studying something, can we be careful that we don't tear it up? Also this, and this is from William Bruce Cameron, Informal Sociology, 1963. It's been said that Albert Einstein used to write this up on his blackboard when he was giving lectures. Not everything that counts can be counted, and not everything that can be counted counts. There are things about palliative care, spiritual care, what we do, that it's hard to put a number on, or especially to put a dollar amount to. So when we think about spiritual care and we think about what is that return on investment to those people paying for our health care, why should they invest in spiritual care? I want to point out that we cannot reduce all good outcomes to a matter of dollars. And even if we could, we'd have to look a lot further for those savings than where we do. It's not just the money that could be saved in the patient's healthcare utilization, but also the family's future healthcare utilization based on their experience. Also, the possibility of clinical staff burnout and turnover, and what we see spiritual care teams doing now to support staff, and thereby decreasing medical errors and threats of litigation. The effects this has on spurring philanthropic giving, and many other hidden costs and benefits. So even if we try to attach that dollar amount, the odds are we're missing many of the important things it can do. You know, so ultimately that triple aim around value-based care reform, which says we're looking for better outcomes for populations, a better patient and family experience, and all at a lower cost, really can't be done without also taking care of the clinicians providing the care. And in my experience, that's often a part of spiritual care. In palliative care, we say the unit of care is the patient and family. In spiritual care, sometimes it's the patient and family and the healthcare team and others that are also part of that unit of care. So when I talked to Ron recently and said, what are you doing at Norton Hospital to help with the pandemic response? He said, we decided very early that our pastoral care teams were going to be all in for supporting the staff. How do you put a price tag on that? And so I'm going to wrap up and say my wish for all of you is that you take care of yourselves and others and you stay safe. Thanks.
And a big thanks to you, Joe. The many ways that you came at this response to me are moving, especially your vulnerability and your willingness to kind of share your practice in medicine and your collaboration with chaplains and this whole enterprise of healthcare and medicine. So thank you so much. I know we have a few minutes left for questions, and I so appreciate those who have offered those to us, and I am recognizing, of course, that probably won't happen, that we'll be able to get to all of them, but I do want to offer some thoughts, and I'll start with a really practical one, Lynn. And perhaps this is for you, Dr. Ernecoff. Can you say a little bit more about the studies themselves? I know you can't get too deep into the weeds, but one of the questions was, of the studies you mentioned, were they at multiple hospitals or were they at a singular medical center? Could you say something about that?
Sure. So the first study I talked about, the qualitative study, was at 6 institutions across the country, both academic and non-academic. The latter 2 studies I talked about were both at the University of North Carolina Health System.
Okay, thank you for that response. Somebody had made a comment here in the beginning to get us going with the questions and answers, and it was sort of like I said, it was kind of a comment and not so much a question, but I'm kind of curious about both of you, given what you had shared from the whole realm and dimensions of from very scholarly to very personal and practical, practice-based response, but hope. I'll just kind of summarize by saying the person said that hope is not a binary kind of consideration. It's more of a continuum. And I'm kind of curious how both of you respond to that, because there's a lot written in the research about hope, but it's also in our practice, and it's all over, of course, palliative care. If you'd respond.
Yeah, absolutely. So this is something that I think palliative care, end-of-life researchers think about a lot. And it is, I do think that it's a continuum, but also on multiple axes. We often think about hope as, you know, someone hoping for something in a clinical context, as clinicians or researchers, as hoping for something maybe medically infeasible. And that is a definition that's too narrow. We can hope for all kinds of things. And often in palliative care, we see ourselves hoping for different things, smaller things, more existential things. And so we really do need to be, and it's a good mechanism for reframing clinically as well when I talk to my clinical colleagues. But hope is multifaceted. And I think researchers, myself included, have used too narrow a definition for too long.
I sure agree with that. And, you know, there's probably no better single definition than the Emily Dickinson poem, "Hope is the thing with feathers." It's slippery. But I would say that not only is there a whole spectrum of things people can hope for, but we tend to think of hope as being somehow in the future, like I'm looking towards something I hope will happen. But I think you can see hope as something you experience in the moment too. And I've had this experience of you see a family where the patient knows that they're sick and dying, the family knows they're sick and dying, so does the healthcare team. Nobody's said it. And that delicate dance is really disempowering to the patient because, you know, since nobody's acknowledging they're dying, they're not having this conversation they really want to have. And so you deliver bad news. You deliver the bad news that they're dying in a helpful, thoughtful way. And at the end of the meeting, you look and the patient's more relaxed than they were when we started. The family's more relaxed than when we started. Even we, the healthcare team, feel like a big burden was taken off our back. And you say, what was the effect of this conversation I had with you? And they said, Doc, it gave me hope. And what hope meant in a case like that is it gave me hope that I can, no matter what, I can still be my whole self, or hope that I can be in control, or hope that the things that matter to me still matter. And that's not a future-oriented hope. That can be a hope that happens right now.
Natalie and Joe, thank you for your responses. And as I know we're just about at the top of the hour, so I am at the risk of venturing into one more question. I'm going to steer off and turn the reins over to Transforming Chaplaincy's project coordinator, Andrew Andresco. Andy, do you have some final words for us about some practical details?
Right, so the presentation is being recorded right now, and I should have that uploaded to our YouTube channel at least by tonight, perhaps tomorrow. What I will endeavor to do, normally what we do is we promote the recording in social media and in our forthcoming newsletter, which wouldn't be until December. But what I'm going to endeavor to do is to reach out to all of you folks who have registered, send you the link, let you know what's up. It's free. Yeah, and Paul, do you have any other questions that I should address?
No, just please check out our website. Please give us a holler. And I just want to say an enormous thanks, of course, to Drs. Ernecoff and Rotella, to George Pachette, to you, Andy, and to everybody who attended and was a part of this. Thanks for your investment into spiritual care, whether you're a researcher or somebody who does it at the bedside or chair side. Thanks very much. Blessings.
Fantastic. Thank you. Thank you, everybody.